welcome. Thanks for joining us, everyone. I'm so excited. This is Dr. Stacy Greeter and Alie Garza with Chronically Real and Clinically Relevant. Joined today by reproductive psychiatrist, Dr. Anna Glezer, who has her own really cool podcast that I admire. Tell us some about yourself, Dr. Glezer.
Thanks for having me, first of all. It's really a pleasure to be here. I also love the name of this podcast. I think it's awesome, and I'm glad to be here. So I'm Anna Glezer. I'm a reproductive and integrative psychiatrist. I practice in California. My clinic is women's wellness psychiatry, which I started back in 2017 to really kind of fill the gap in women's mental health across the Bay Area and now across all of California. And my team and I were psychiatrists, psychotherapists. We like to be collaborative. We love to learn, and really learned so much actually from you, Dr. Greeter, just the other day on managing neurodiversity and how to diagnose and how to work with patients who are neurodiverse. And that was really, really informational, educational. I've gotten such positive feedback about it. And
Thanks. I'm happy to come back and info dump about autism again sometime. I do that quite a lot, don't I, Alie? Yeah. Tell us some about how women's mental health and reproductive psychiatry became a passion of yours, if you could.
Yeah, well, I've always been interested in women's health in general. And so I actually thought strongly about going into OBGYN in med school, and in my fourth year, did some additional rotations in REI and just some additional OBGYN related rotations. But I knew that psychiatry was really going to be my passion. And it was, I enjoyed all of the different rotations that I had in med school. But so it was hard to answer the question, what do I want to go into? But when I thought about what would I miss the most if I didn't go into it, that was going to be psychiatry. And so I went into psychiatry, and I trained at Mass General Hospital for residency, and they have a really strong reproductive psychiatry department. They do a lot of research. And so I was able to work with that team and kind of dive more into reproductive psychiatry that way. And then when I moved out here to California, and after a year of fellowship at UCSF, I started at my first attending job, which was at UCSF, and was the first embedded psychiatry in the OBGYN department there. So I really got to kind of develop that clinic and that practice embedded in their OB department. And it's that my interest and passion in that work has really just kind of grown from there. And the integrative piece, which is a big part of how I work these days, really developed more from the patient side of things. I think a lot of patients were looking for this kind of approach. And so I just became more interested, got more education on the topic, and developed my niche at that interface between reproductive and integrative psychiatry.
Dude, a whole nother episode could be on integrative psychiatry.
Totally.
That'd be cool. Okay. Right. But okay, today we planned to talk about infertility and reproductive trauma, which I will say I'm personally impassioned to talk about, because I don't feel like we get any training in it at all during our residency fellowship training. I didn't, and B, I don't think that it's being discussed enough, the psychological impact of infertility and reproductive trauma. Personally, have been through my own am currently going through my own very complicated reproductive journey. And we're, all things going well, knock on whatever you want to knock on, are hopefully welcoming a baby made with an egg donor and my husband's sperm, and gestated in a gestational carrier, hopefully coming around New Year's. So, and that's been literally, I think it's been like a 6 to 7 year process in my life of trying different things to culminate in this unique journey to parenthood.
Yeah. Yes.
So, okay. So my first question would be, if you got all mental health professionals together, okay, so like therapists, psychiatrists, you got them together, and you get to be on a soapbox and tell them something, like what you most want people to understand better about the psychological impact of infertility and reproductive trauma, what would you say, Dr. Glezer?
I
No
think the
pressure.
challenge yeah, I think the challenge is that so
Yeah.
many individuals who are going through this experience aren't necessarily talking about it, and it's
Right.
often a lot of silent losses and silent struggles,
Yes.
and
Yes.
there's just so much silence around it, and I think the number one thing that would be really important is more sharing, and I've heard so many
Mhm.
stories where, one of my patients will share with me that, maybe she's gone through a loss as part of the journey because that's a key part of most individuals' journeys, and, you know, will have maybe mentioned it to someone, and then that someone will be like, "Oh, well, I had a similar experience with this, that, and the other thing." And, that connection, and they're both so surprised that this is something that the other person has gone through as
Right.
well. And that happens so often because no one is talking about
Mhm.
their fertility journeys. And I think there's a lot of, for lack of a better term, like positivity washing of the experience. I just kind
Yes.
of made that up, but
Mhm.
I think that happens a lot where you're sort of almost pressured to kind of smile and buck up and kind of go through the steps, and the journey could be, as you said, many, many years long, and can definitely almost kind of take over for some people in terms of, their world, both in terms of the timing and the logistics, because it can be really involved with lots of different appointments, but
Yeah.
also from a mental health perspective, it turns into at least a part-time, if not a full-time job and mental occupation. And I think there isn't a lot of training at all on this, certainly not in psychiatry. I don't think there's also much training in the OBGYN world, certainly not
Mm.
on the psychological aspects. And I
Mm-mm.
think part of the trouble there is some things that are very common in the OBGYN world are sort of just kind of glossed
Off.
over
Yeah.
without, the fact that just because, let's say pregnancy loss and
The
miscarriage
early
is
pregnancy loss.
X common, whatever the percentage is, doesn't mean that for the one person who's, like, right there in front of you, it is so easily glossed over. It's a loss. And so I think that's one of the fact that mental health professionals don't get that training, reproductive health professionals don't necessarily get that training, and then there's just a lot of silence around it, and I think silence can lead to things like shame and stigma and all of those kinds of co-occurring
Totally.
experiences. So
Yeah.
my number one solution is to talk more about it.
Okay, let's do that.
I think what's interesting too is that when I think about mental health and like in this realm, I hear a lot about like postpartum, like in my world, especially like postpartum OCD and, how do we treat that? How do we manage that? But when I was at CU Anschutz, our clinic, our OC clinic was actually attached to the perinatal clinic.
Mhm.
And suddenly I got to learn a whole lot, like that the word perinatal, what that actually meant. And that it meant like everything encompassing that, including during. And I feel like there's very few conversations about in the midst of pregnancy and also, of course, like in the midst of infertility or loss, and a lot of focus on like then when the baby's here, the postpartum piece of the journey. And so that's been something that I think is, yeah, I've been surprised about how little I hear about that. And as a clinician, also how no training, right? Of like in the midst of that. And how do we manage that grief piece and support people through that too?
I like Have you read any of Janet Jeffay's books on reproductive trauma, psychotherapy with infertility and pregnancy? Okay, she has reproductive trauma, psychotherapy with infertility and pregnancy loss clients. It's a good book. I'm just going to throw that in there. And talks about rewriting one's reproductive story that you had in mind, and then grieving. It's like grieving the future you envisioned,
Yes.
um, as a particularly unique type of grieving. And then also grieving a certain identity that you had for yourself in terms of becoming a parent. Yeah, do you have any thoughts, Dr. Glazer, how the grief is unique?
I think that that really hits the nail on the head is the uniqueness of that grief, because
Mhm.
when we typically think of grief, let's say someone loses a grandparent, for an example, right? When you kind of reflect on that relationship, you have so many memories that you might be able to kind of reflect on and remember and nurture yourself with. And I think the challenge with this kind of grief is that it's a future oriented kind of grief,
Mhm.
right? It's a loss of expectations or a loss of a vision or a loss of a dream or a loss of something that's in the future that hasn't come to fruition yet. And you don't have those memories of experiences to rely on. And so it is a very different kind of grief. It's a little bit more intangible, I think, for some people. And I think that makes it unique, both in terms of the experience of it, but then also how do you grieve something that is more intangible? And because when we're talking about grieving, the loss of a relationship, we can always and often rely on those positive memories and things like that, but we don't have that. And so it is a very different kind of grief. And like you said, it's also a shift in identity, because it might be you had a very particular vision and definition of, let's say, what being a mother means. And you might need to shift that definition. And that's an identity change. And maybe
Yeah.
that's one that you had created when you were young. And now, I don't know, 30, 40 years later, you're having to change that.
Um, and then another thing just came up on my head because I think if there's a statistic, I'll find the article that 25% of female physicians struggle with infertility. You've seen that one? And yes, I feel um there's even though it's like intellectually we understand that, sperm meets egg is a biological process. Psychologically, we take on responsibility and think that if we're not pregnant yet, we're not trying hard enough, we're not doing it right,
Mhm.
as like a personal failing. And I also think society contributes to this, which
Uh-huh.
aggravates me a lot. Okay. People would constantly tell me, as soon as you stop trying so hard, then you'll get pregnant. Right.
Yes.
All the
Yes.
time, things like that. That there is something psychologically I was doing wrong somehow that would made me not yet pregnant.
Right, and honestly, the reason that statistic is so high is because of that delay that female physicians have in terms of
Yes.
starting their careers, and therefore because we're told both directly and indirectly by the way that, training is scheduled, that this is something that you need to postpone until you're in a better place to do it, because it is really hard to go
Yeah.
through something like that while you're in training and in school. And so you're told to kind of postpone it. And by the time that you finish all of your training, maybe at the earliest, you're in your early 30s, but for many, you're in your mid to late 30s. And you're really just kind of starting to get established. And then you're told, well, maybe now's not the best time because you're just your first couple of years after training, you need to get established. Because of the way in this society that there's definitely a tax, so to speak, on professional development and acceleration that happens. And so you might not necessarily want to pay that tax early on. And so you kind of keep postponing. And so, yeah, it makes sense that a quarter are struggling with fertility. And I think there's also kind of this sense that we have the technology. I'm sure it'll be fine. There's just a lot of kind of that sentiment that you can postpone and it's going to be fine, because, well, maybe you could just, let's have everyone freeze their eggs at 30 now, and then you're protected. And I think the challenge that sometimes comes up is I've known a number of different individuals where they've taken out that insurance policy, so to speak. And for whatever reason, it hasn't worked out. And so then they need to, again, shift their plan and come up with alternative ways of building their family. And so I think I'm not surprised that it's that high. And I think the way that we structure our training, but also just bigger societal expectations
Mhm.
for women in motherhood, it's not surprising that the numbers are that high.
Yeah. And just the experience of well, I went through IVF multiple times. And I'll just say I remember, um, I had I wisely, actually delegated to my partner to keep track of the medication part, it's so many last minute appointments. Um, I felt pretty horrible physically with the medicines. And then I was sitting in the infertility doctor's office and he was like, "Okay, do you have such and such medicine?" And I just said, "I don't know. I'll ask my husband." And he was like, "You should be on top of your medicines and know where your medicines are." And that simple statement, right? Because you're in such a place of vulnerability and feeling inadequate due to your struggles with the infertility, right? I remember just panicking, crying on the way home, like, can you go home from work? Is the medicine there? Do we have it? Did I just screw all of this up because I'm um not adequate enough to be a mother because I was trying to balance, my professional life and these fertility appointments, and I don't happen to know if this medication is at home, right?
Yeah. And that's
Just
You know,
yeah.
that it's so unfortunate because again, it puts all of the responsibility on you, right? As opposed to the fact that there's actually 2 people who are going
Yes.
through this.
Yes.
And the other person also both needs to be involved and I'm sure would like to be involved. Um, and so that person, their participation in the way that you guys decided to delegate it was like, that's the person who's in charge of this part of it.
Right. I hear you. And it's hard. I'm grateful to my partner. But yeah.
Curious about, me and Stacey both have lived experience with OCD,
Yes.
and I've been navigating the fertility journey as a person with OCD,
Yep.
and having
Let's
so
talk
little
about that.
tolerance for uncertainty, and then
Yep.
process that's filled with uncertainty. I'm curious also, I think that, the thought of like, and there's all these illusions of control, right, in the world. And
Mhm.
I think about like your example of like freezing your eggs, this kind of illusion of control of like, if I just am on top of things enough, if I plan enough, blah,
Mhm.
blah, then that my outcome will happen. I need it to happen. I'm curious how infertility and then folks who already have pre-existing OC or these anxiety related disorders, how you see that combination through infertility or reproductive trauma.
Yeah, I think to your point, I think it can definitely make it harder when one of the most significant challenges with anxiety, just like big picture anxiety, is uncertainty and loss of control. And kind of that one of the ways that an individual with anxiety manages their anxiety is by having control. And when you remove that tool, it makes it so much more difficult. And I think, there's small ways where people try to kind of find that by, well, I'm going to eat in this particular way, or I'm going to, do this thing that I can do. But again, recognizing that there is so much that is outside of our control. And then we just have to kind of sit with that uncertainty, especially,
Yeah.
let's say if is doing IVF and they just had a transfer, and then you have to sit there for a couple of weeks with uncertainty. And
Yeah.
there's really nothing that you can do but sit there with that uncertainty and kind of practice that. I mean, one of the things that I talk to some of my patients about is that in some ways it is good practice to not have that control because when the, when if there's a baby at the end of this, you also can't control the baby. And so that is
Yeah.
sort of, you're practicing not being able to have some control by not having control in this part of the
Right.
journey. So it can be helpful in that sense, but it's really hard experience to sit with.
Yeah.
I think especially when like when you're the type of person who's perhaps celebrated and really identifies with being proactive, productive of like I'm going
Right.
to make it happen, of this backwards feeling of like, what do you mean I'm just supposed to sit back? That's all I can do, right? There's got to be more.
Right. About this huge life change that you really want to happen, right? Yeah. What about partners too, romantic partners? I don't think that we have enough. I don't know, like acknowledging, like you said, Dr. Glazer, 2 people are going through this. And I feel like I'm always trying to encourage romantic partners, and especially the men, to be able to express their grief and lean into it and be able to discuss it with their partner, almost like I feel like they have this sense that they're supposed to, because the woman went through the miscarriage and the woman is going through the medication treatments, and the woman might be that it's almost like they don't have the same right to lean on them for support. Am I making sense? I don't know if I explained that well,
Yeah,
but
I think that's
how are you
I
experiencing
think that's
that?
exactly true. It's sort of the sense that, the male partner,
Right,
in, kind of a hetero normative
right.
couple, the male partner is supposed to be the support system. And I think one of the things that I often encourage the male partner is you don't necessarily need to lean on your female partner as the support system, but you need to have a support system. And maybe that is a therapist, maybe that's a friend, maybe that whoever that is, but it is important to recognize that you're also going through this and I'm sure you have expectations and dreams and things that are diverted because of the roller coaster experience of a fertility journey. And so having the opportunity to kind of process that so that if your primary goal is also to be a really strong support system for your partner so that you can do that effectively, and kind of just constantly ignoring your own emotional experience is going to eventually make that much more challenging.
Yeah. Totally. And I think there's this message too in society, where they say, "Oh, don't tell anybody you're pregnant until you're at such and such weeks." Right?
Uh-huh.
The implicit message being, well, early pregnancy loss is so common that, you should not burden other people with this very sad and like also physically uncomfortable, like physically hard process of an early pregnancy loss, right? Like don't burden other people
Mhm.
with that information. Just keep it to yourself.
Yeah, and I think that speaks to just our culture in general, right?
Mhm.
Just when you're talking to someone, "How are you?" "I'm good." It's always, "I'm fine." It's always, "I'm good."
Mhm.
It's never, "Oh, I had a really hard day," because you don't want
Right.
to, quote unquote, "burden the person with whatever is going on." And so it's always, everything's fine. And so part of it, I think, is you as the person going through it might have sort of the sense of, I don't wanna burden people. I think because we also don't talk about this topic nearly enough, the people around you might also not necessarily know how to respond effectively and might put their foot
True.
in their mouth more often than not,
Yes.
right?
Yes.
And then that causes tension in the relationship. But I've had a number of patients where they have shared early on, and that means that when there is a loss, they have more people to potentially lean on for support, which can be so valuable.
What do you think are the other kind of greatest barriers to people sharing, especially like with early pregnancy, that concept, right? Do you feel like part of it is because like that's also hand in hand with like feeling like that grief isn't valid and therefore like I'm not going to put it out there because then if something happens, then it's not as valid as a different type of grief. What are your other thoughts on, yeah, the barriers for that?
I think that's really spot on for sure, where it's a sense that, I I think we do a lot of this in general where, well, I can't be upset about my situation because someone else's situation is worse. I mean, just because someone else's situation is different doesn't mean that I can't be upset about my situation. And I think that happens quite a lot here where also keeping in mind that, different people are going to respond very differently, right? Like there might be two different people who, let's say, have a loss at 6 weeks. And for one person, it feels very different than for another because they've just had a different experience of conceiving in the first place, different expectations, just a whole bunch of differences between the two. And so I think it's important to recognize that your experience of a loss might be very different than someone else's experience of a loss. I think there's also, again, even beyond the fertility piece, people are uncomfortable with grief and loss, like big picture too, and often don't really know how
Yes.
to respond to someone who might be in a grieving process, whatever they might be grieving. And it's often a lot of
Mhm.
platitudes
But it's silver
that
lining it. Mhm.
yeah, yeah. This was meant to be. You're gonna,
Yep.
this is gonna happen
My
next.
friend was told this is meant to be. She like one of my friends who just had a miscarriage, like early pregnancy loss. That's what someone told. Yeah, it's so common. Sorry, I interrupted you, but go
No, I
ahead.
mean, that's so common.
Yeah.
Um, and it just people don't I mean, in general, I don't think we're often taught how to help someone through a grieving process and how to hold space. And so people get really uncomfortable. And so when, the number one piece of advice that I can give really anyone is if you're not sure how to respond to someone who might be going through a grief or a loss, you can ask them what might be most helpful, right? You don't have to come up with it necessarily yourself or be so uncomfortable that you avoid the topic altogether. And then that creates friction and tension and uncertainty as well. So, the number one thing is to hold space for whatever they might be going through. And if you're really unsure, then ask someone what might be most helpful.
Like, thank you so much for sharing that with me. How can I support, or what do you need from me?
Yeah. Yeah.
Yeah.
Curious about also, I was telling Stacy this story a couple months ago. Of I went to my neurologist and was talking about basically, oh, we're trying to get pregnant, blah, blah, blah.
God, it's gonna make me so mad, Allie.
I know.
Okay.
And he looks at the med list and like, I have ADHD, I have OCD. He's like, well, you're gonna have to get off of all of these before you do this, right?
Right?
Now, imagine, I mean, imagine I had untreated health OCD and would have, in the midst of trying to get pregnant, hearing that,
Right.
how if I wasn't where I am at now in my OCD journey, how horrific that would have been and sent me spiraling. I'm curious about how that shows up for your patients too, like navigating the medical system at large and potentially other people unintentionally, for the most part, putting gasoline on the fire in the midst of this journey too. And how do we support patients through that?
That's such a common thing. The number of patients that reach out to me because they say, so and so clinician told me that I need to stop all my meds. Can I get a second opinion? Like that's such a common request. And,
Like, why is
you
it
know,
still happening?
the nice thing is, at least for those folks, they're not automatically just stopping everything and then,
Right.
struggling. They're asking those questions. But for every one of those folks, there is someone who probably is not necessarily getting another opinion and is just following those recommendations. And I think it's still true that we have such little content in med school because it really needs to happen in med school because all of these people are going into various specialties that, because you neurologist, whoever it might be, but also plenty of psychiatrists have that same kind of mentality. And I think it's interesting because, and this I think goes back to also the stigma associated with mental health, because if you were on, let's say, medication for IBD or rheumatoid arthritis or something else, there's a full conversation to be made where you're given the information you need to make an informed decision about what might happen to your condition and etc. Whereas with mental health, it's often like, oh well, you just stop your meds and
As if the meds are kind of like a luxury, might be nice, versus vital to one's psychological, physical well-being and also to having a healthy pregnancy.
yes, exactly. And so, I mean, I think there's lots of folks out there who are trying to do this kind of education for clinicians and
Yeah.
for their patients,
And
but we
thank you
definitely
for
have
your
a ways
work doing
to
that, Dr.
go.
Glezer. Thank you. Thank you for fighting the good fight.
Doing my best over here.
Thank you.
Yeah,
Yeah.
luckily I was able to say that I'm working out here with also a perinatal specialist psychiatrist who also was trained at Harvard. I'm like, maybe you all knew each other. So that's where I was like, all right, but I'm gonna put that on the shelf, right? And go talk to her about it. And it's just astounding to me how, I even had this visceral reaction, like despite being in this is my entire career is mental health and like I getting information from prescribers and other clinicians and even that it just shocked me, right? And also just how easy it is for misinformation to spread even within the medical field. And so that's something that I've been trying to encourage patients to of like you have to be thoughtful, not only with like getting opinions from friends and family, that's one thing, but even just within the realm of like who are the specialists out there. Because it's really intimidating when then some middle-aged man who's an MD is telling you you need to be off of these. And I'm like, goodness, what am I doing? So, and I think even more so amping up that like, and therefore something bad happening is my responsibility, right? If I take these,
Yes.
like, what does that mean that I am not in control enough, that I'm being reckless, right? And how that could just amp up just the process of
Yeah, the
managing the insurance.
guilt, the misplaced
Mhm,
sense of doing something wrong.
mhm. Yeah, yeah. That sense of, I'm responsible for every single, and it goes back to that piece of control, right? Like that sense of, which is, perpetuated by these kinds of experiences, right? If you're responsible, then you must have control, except you don't and you're not.
Yeah. I'm going to give a shout out to Massachusetts General Hospital's Women's Mental Health Center that people can use to get really great up to date information on reproductive psychiatry. And I know Dr. Glazer also has tell us about your program, Dr. Glazer, for that.
Yeah, I mean,
Yeah.
the Mass General Hospital website has such in-depth
Yes.
information, and then they also do a lot of, like, training for clinicians.
Hmm.
The online course that I run is focused a lot on integrative tools and approaches to reproductive mental health. So it's geared towards all kinds of clinicians that are interested in a lot of those non-conventional tools, thinking about micronutrients, thinking about holistic health approaches, thinking about lifestyle medicine, all of those kinds of things for reproductive mental health. PSI, Postpartum Support International,
Yep. Yep.
also has a wealth of information. They run both a prescribing hotline for anyone who has questions. And so, for example, if that neurologist, Alie, that you were talking about,
Right.
had questions about those medications, they could have, contacted the
The
hotline.
information is there.
Um, and so, and then they also have so much support for individuals who are going through pregnancy and postpartum. And then for the infertility piece, Resolve is a really great organization, kind of national organization that does also a lot of education, but also really important advocacy.
Thank you. Thanks for those resources. Yes, and I made a Disney princess case-based presentation on reproductive psychiatry. Snow White was my postpartum OCD case because she kept cleaning,
Huh?
and Ariel was my autism ADHD case, and then Anna and Christoph were struggling with infertility in their reproductive journey, and then eventually decided to grow into no longer having a genetic monarchy, right?
I love it. I love it.
Sorry, I digress. But anyways, yes, yeah. Thanks for those resources. And I listen to your podcast too a lot for
Yes, and
that.
if anyone's interested in listening to that, it's the Women's Wellness Psychiatry podcast, and Dr. Greeter was just a guest on the podcast a couple of weeks ago, and it was an awesome conversation.
Thanks.
Thank you for joining us. I know that this is a huge area that, I know in my realm that we rarely talk about. And I think there's a lot of mystery there for patients going through. And I think that isolation piece is huge, right? Of feeling like you're the only one. I guess that is similar to the OCD realm too, but feeling like this is something that I have to keep to myself. The stigma, the fear of being misunderstood or something being directed as my fault, I think is that common thread too between these two things going on. Um, Curious about, just for a final thought, what would you say are the biggest gaps when it comes to integrative care, for integrative psychiatry for this population, or the areas that should grow ideally?
I think a lot of people in general, integrative psychiatry is a little bit more of a novel concept. And I don't think everyone understands really even what it means. And I think people sort of assume that it means that you're not going to take any medication, for example,
Right?
or use any conventional tools. And it really doesn't, because if you look at just the Merriam-Webster definition of the word integrative, you're including everything as
Right. Right.
opposed to.
More inclusive, not excluding medicine.
Yes, exactly. And so, I have patients who are going through reproductive journeys, and they might be taking psychotropic medication, and they might be, optimizing their mental health by adding certain micronutrients or supplements. They might be engaged in psychotherapies of different kind. They might be doing some breath work. They might be really focusing on their nutrition or using movement for mental health or ecotherapy or Chinese medicine or any number of other tools. And I think the point of integrative psychiatry is that you think about, what are some of the root causes of what's going on, and how can we, holistically include all of these tools at our disposal for someone someone to feel better. And I think that's something that can definitely be applied to those who are going through a really difficult fertility journey.
And correct me if if you think I'm wrong here, but I've always thought about integrative psychiatry as just basically being really good psychiatry. Like good psychiatry should include we're discussing nutrition, we're discussing sleep habits, we're discussing do you have purpose and meaning in your life? We're discussing physical activity. We're using more than just one tool to help you lead your healthiest, most fulfilling life. And we're not just making sure you don't die. We're trying to help you actually thrive.
Yes.
Um, and I could go on a soapbox too, because I feel like our entire healthcare system is like, well, is your vitamin level low enough for you to be like severe, severe, severe? Okay, it's not. All right, fine, forget it. Right. Versus like what would actually put you into a healthy, functioning place not just not being in a completely diseased place, but actually in a healthy place.
Yes, exactly. There's, I like to think of, that span where you have disease
Right.
and then you have, health is not just the absence of disease. You can keep
Exactly.
going
Thank you. You said
down
it better.
the spectrum towards, optimal wellness. And I think
Yes.
that we don't have to just stop when disease is no longer readily apparent. We can keep going down.
Yeah, I'm going to remember that. Health is not just the absence of disease. Thank you. I like that. I'm going to use that one
Please.
for sure. Yeah. Any other final thoughts on this topic too, Dr. Glazer, before,
I'm just
this
so glad that
broad,
we're talking about
open
it because,
ended?
that's the number one thing is to talk about it more. And hopefully for folks who are listening, who are going through a difficult, fertility journey, they're feeling supported and they can maybe feel a little bit more comfortable reaching out for support and sitting with some of that uncertainty. And then for folks who might have people in their life who are going through this experience, hopefully feeling a little bit more, um, just being that support person and saying things that are going to be healing as opposed to, putting their foot in their mouth.
Yes. And then also I think recognizing that the one really important thing I want to emphasize is the trauma of an infertility journey does not go poof once the baby is here. And
Absolutely.
I know, and I think that's shocking for a lot of people. And they're just like, oh, you tried so hard to have this baby and the baby is here. So everything is great now, right? Like that does not erase all the trauma that that person went through. And I think that's surprising for a lot of my patients and their families.
Exactly. And I think it becomes sometimes even more challenging in the postpartum when there are any kind of mental health struggles and there's a huge sense of feeling, guilty that, oh, I went through all of these
Mm-hmm.
challenges and I'm supposed to be perfectly happy now. Everything is supposed to be perfect now. And it doesn't quite work that way. And there has to be the opportunity to reflect and process that trauma. And you carry it with you. And it's important to be able to take the time to really understand that and to kind of grow through it. And just because there is a baby there, like you said, it doesn't negate the prior decade or however long it was.
Yeah. And that's like something that I could never imagine someone thinking in other realms of grief and loss, right?
Right.
Thinking something like that or saying something like that. I would imagine is a unique kind of, yeah, like, and therefore this should all no longer be a challenge because of this end result. Whereas you would never hear that for another type of loss, right?
Yeah.
All right. Hopefully, I'm excited. I'm excited for people to hear this. For people out there, you're not alone. You're not alone out there. You're not broken or inadequate. It's okay. It's okay to be envious of other people who reproductive journeys have gone easier. It's okay, to have all of these feels. That does not in any way diminish your caring or love for those people. It simply reflects the level of your hurt and how much you care about the reproductive process that you're going
Yes.
through, right?
Yes.
So Thanks so much, really.
Thanks for having me. This was a really good conversation. I'm glad we had it.
Thanks for listening to another episode of Chronically Real and Clinically Relevant. You can find us at stacygreetermd.com and
OCDandanxietycolorado.com, and we encourage y'all to keep it real
and stay curious.